All right. It's my pleasure to introduce Dr. Sourat Darabi, who's going to talk to us today about reversion mutations. This is part of our VICC Virtual Molecular Tumor Board variant type series, and so I'm just really excited that she's able to come here today and share her expertise with us. So thanks so much.
Thank you, Beth, and thanks everyone for attending. And this is a great opportunity to present this aspect of precision medicine. So I will, is that okay if I start sharing the screen and present that?
Yes.
Okay, you see my screen?
Yes. Looks
Okay,
perfect.
perfect. Again, my name is Sourat Darabi. I'm a director of precision medicine program here at Hoag Hospital in Orange County, California. And this is where we are located. So this is one example of these case series, but I picked the newest case that I just presented at our molecular tumor board last month. This is a 44-year-old woman with diagnosis of recurrent metastatic ovarian cancer, status post diagnostic laparoscopy with biopsy of peritoneum in November of 2022, surgical patch show recurrent high-grade serous ovarian carcinoma. Our GYN oncologist treated a patient with 6 cycle of carbodoxil, cycle 6, although was and due to shortage of carbo was changed, but continued until July of 2023. And then after that, started on Lynparza, which is a PARP inhibitor, just moderate bloating, but overall was tolerating it. And in 2022, we also did molecular testing. We sent as an institution, we sent our molecular testing out to the clinical laboratories. So this molecular testing was sent to a laboratory that doesn't do tumor normal. It's just the tumor tissue testing. And they identified a BRCA1 mutation. HRD was positive, FOLR1 positive, 2 plus 75%. They identified a TP53 mutation. PDL1 was positive with the CPS score of 1, ER negative, PR positive, TMB low, and MMR proficient. In cases like this, we usually, in general, our workflow is all ovarian cancer patients need to get genetic counseling and genetic testing. Most of our recurrent cases of ovarian cancer go in a reflex testing protocol to the molecular testing. So it depends on which one is done first. If the molecular testing comes back positive first, we recommend germline genetic testing. So for this patient, we had a germline genetic testing confirmation for the mutation that we identified in a tumor sequencing. Then patient was also progressed later on. We did another molecular testing. FOLR1 was positive with 80% HER2 negative by IHC. They identified the BRCA1, the same BRCA1 mutation, and also another BRCA1 likely reversion mutation. From that sample, patient has been on carbotaxol, Avastin, and then patient plan on to have surgery, debulking, and cisplatin HIPEC, then back in December. A little background about BRCA reversion mutations. So this is important in terms of understanding in the precision medicine setting. We do a lot of good work in targeted treatments, and following this patient, do molecular testing. However, all these treatments that we do in terms of targeted treatment have a resistance. So these resistant mechanisms are also now very important to understand and how to monitor those. In terms of lung cancer, we have resistant mechanism like in TKI, like EGFR secondary or tertiary mutations, and so forth. So for PARP inhibition and platinum-based therapy, we know now that there are reversion mutations. These mutations usually get a second hit on the same allele that potentially corrects the defect. So that's how the treatment may not be effective. Is either like through a second frame shift mutation, the correct reading frame, or point mutation. The laboratories, they call these variants differently. Most of the ones that I've seen, they call it a VUS, but they call it like also likely reversion mutation because of the mechanism. As in the past, the PARP inhibitions were originally approved for ovarian cancer, but nowadays we do that for treatment for a lot of other cancers. That's what we see more of these reversion mutations pan cancer because of the treatments. And this basically, this figure on the right shows that like how this germline mutation on this specific case represent the BRCA2 mutations. This is pre-treatment and a post-treatment. We see that the secondary reversion mutation. There are several studies. Some of them are case studies, some of them are case series that are published in reporting reversion mutations, although they're not limited to just BRCA1 or 2, but my focus here now is just the BRCA reversion mutations because of our patients. So I include a few slides on different way of detecting these and how these are reported. So this specific study is like an older one. They reported primary and acquired resistance to PARP inhibitor rucaparib in high-grade ovarian cancer. So they basically look at the mutations in this group, and they found that patients that they didn't have BRCA reversion mutations pre-treatment had significantly longer progression-free survival than the ones that they had reversion mutations. So, and this is the case from that article, and as we can see, we may see several reversion mutations, not just one in one single patient, and is depicted here in this figure on the BRCA1 mutation in a pretreatment patient. There is another research published, and they looked at circulating-free DNA for therapy-resistant in breast and ovarian cancer cases. These are two patients. One had one reversion mutations, the other one had two. These can be now detected on liquid biopsy blood samples as well. We have a better direct detection now. If we don't have a tissue is always, in terms of clinical setting, is a high standard, but if we don't have tissue, serial liquid biopsy also would be beneficial. So it's a lot of research from a functional, from the clinical standpoint are going on reversion mutations, how we can predict them, that if, these certain patients may be prone to have reversion mutations and resistance versus other ones with the mutations at baseline. So these researchers, they'll look into hotspots or areas in the regions that they're suggesting some mutations may to have a higher rate of risk of reversion mutations than some other mutations by this group that they analyzed, 300 reversion mutations. Also, it's important to understand the landscape, because I in precision medicine, I present at different tumor boards. Most of our tumor boards are molecular, meaning that we present at all our tumor board with that patient has molecular results. And often I get the questions, what happens should this if patients done surgery and we removed every tumor, do we still have the chance of having a reversion mutation for that patient? Specifically, that question for this patient. So I look at the literature and you see that the evolution of these reversion mutations, this is for one patient published by these researchers, and you can see this is the original somatic mutation, but this is throughout the treatment. We can see several other reversion mutations that were found in serial liquid biopsy testing for this patient throughout the treatment regimen. I'm going to go over this study a little bit, not too deep, because this was just published. And they look at BRCA reversion mutations. They looked at over 3,700 patients in 32 cancer types, and they found 21 reversion mutations, 3 in BRCA1 and 18 in BRCA2. There are some studies also done, not this one, that there's certain exons in BRCA1 or BRCA2 tend to have more reversion mutations than the other ones. There are different mechanisms that they're discussed that leads to resistance to PARP inhibition. This article published last year, they're looking at a review different mechanism, as you can see from directly CEBP beta directly targeted and upregulated multiple HR genes. We can see reverse methylation of BRCA genes lead to HRR function recovery and so forth. There are different suggestions of different mechanisms in terms of resistance to PARP inhibition. This is important to understand how we can overcome these reversion mutations in terms of clinical setting. I always get into a dilemma when I'm presenting these cases at tumor boards. Okay, we have these patients, we treated them, and now they have reversion mutations. So what should we do now? Should we go back and start platinum? Should we do combination therapy? So for this patient, FOLR1 was positive. Should the patient get treated with mirvetuximab? And there are all a lot of questions. Should the patient go on a clinical trials? Still research going on for these patients. So this is interesting database that is at the UK, that they have reversion mutations. They after I published my database of patients, they reached out to me to add my patients to the database. They haven't updated the database yet, but as you can see, and this is when I pulled it on last week, there are, other than BRCA, 1 or 2 other genes in a pathway that they have reports on reversion mutations in this database. They look at these patients, they put them in. You can go into their dashboard and look into the mutations. If the mutation, original mutation, either somatic or germline, and they report the reversion mutations. You can look into some of those if that mutations overlap. There I have a lot of like BRCA 1 or 2 found their mutations and reversion mutations. My patient, this is a specific patient that I'm presenting today, was not part of that reported database. So in 2022, we published this paper. This is a collaboration study with several institutions. We combined our data. This is a test that was sent to Caris Life Science, one of the laboratories that we often use. And we looked into their entire database then to see how many of these patients they found. Just want to emphasize on that these patients were the only ones of how these patients are selected. So these are the patients that were selected that they either had treatment with platinum agent or PARP inhibition. So we look at those patients with potential reversion mutations. As you can see, we have not only for breast, ovarian, prostate, pancreatic cancer, we have for all other cancer types. We identified and reported 32 reversion mutations in BRCA1, 43 in BRCA2, and I don't have much of the outcome data on these, unfortunately, but this is just a total report. So we looked at 247,000 tumor samples, and we found this 75 total of reversion mutations in these samples. We put those reversion mutations in to this two figures, for BRCA1 and BRCA2. This was not a statistically significant, but you see that for BRCA1, we had most of the mutations in exon 10. Well, that could be because of the size. And then in BRCA2, we had it in exon 11. I didn't include that study here, but the other study that they look at their cohort, and they found most reversion mutations in exon 11 on both BRCA1 or 2. So the question came again, so what should we do with this patient? There was a discussion about mirvetuximab or going on clinical trial. So this specific clinical trial, CHEK1 inhibitor that we had open in our institution, so we suggested this is originally out in MD Anderson. And there are few patients on a study that they responded well. I actually have one family member on the study. She's a carrier of germline BRCA1 mutation. She has ovarian cancer, and she's been on a study for the past year, and she's stable and responding to this therapy. However, there are also studies on ATR inhibitors, combination therapy, reintroducing platinum with another PARP inhibition. So these are all ongoing studies in a clinical setting. Now that we have the approval for FOLR1 positive cases for mirvetuximab, there are also studies on FOLR1 inhibitors with a different threshold for IHC positivity, so they can combination. They recommend these therapies of combination therapy, FOLR1 inhibitor plus chemo. It will be interesting to see all the studies come out with the good results, depending on how we can approach these patients, how we can treat them, how we can prevent from, or at least know that this reversion mutations and resistant mechanisms will show up later on in a treatment. Thank you. I know it was a short presentation. I just had one case. I was not sure if you wanted more cases, Beth, but I'd be happy, open to discussion from clinicians on the call, how they can help these patients. Again, disclaimer, I'm not an oncologist, I'm a geneticist, but I would love to hear if clinicians have been treating these patients and how the approach would be. Thank you.
Great. Thank you for that presentation. I thought it was really, really well done, really clear, especially for us. I know I speak for myself when I don't get to see the more clinical side of this all the time. It's more so the molecular results. And so it's kind of nice to see that kind of fit in as well. I have one question to kick off, and then I'll open it up to everyone else. So why do you think it is that reversion mutations seem to be more prevalent in BRCA1 and BRCA2 than in the other genes?
Again, they might not be more prevalent. Maybe we're not just detecting them because we're not doing a lot of therapies based on mutations like on PALB2 or RAD51, as you saw in that database that I was presenting, that there were a few cases with RAD51C and D. But I think as we treat them more with approval for, especially for prostate cancer, with more genes, HRR genes, and that are approved for PARP inhibition, I think we detect them more. I think the reason to me is because we're not actually treating those patients. So we in a few years, I expect to see more of the reversion mutations on other genes. Also, some of the laboratories not even reporting and looking into those other than BRC1 or 2. Maybe that was, I don't know if any of our laboratory colleagues are around this in this call to explain that if they're actually looking for those reversion mutations in other genes than BRCA1 or 2.
Great, thanks. Yeah, that's an interesting perspective because I know there are several laboratories that only will sequence BRCA1 and 2, whether it's due to like reimbursement or just like simplicity of testing or likelihood that they're going to find a mutation in those genes for those patients. Interesting. Well, any other questions for Dr. Darabi? Wait a little bit and then I'll. So another question I had was so you believe that like and I would think too that reversion mutations in different genes are going to be kind of a field of study in the upcoming years. Are there any genes that we should kind of be keeping an eye out for and be having this in the back of our mind, or saying like, okay, is this a potential for a reversion mutation? Or is there like a specific type of gene that we should be on the lookout for? Whether it's like any gene that is targeted by a therapy, or I don't know, I kind of want to get your thoughts on that.
So in terms of HRR genes, I think all of them should be in the lookout as we do more treatments in terms of FDA approval or clinical trials. I think that would be something to consider in terms of reversion mutations. But in general, resistant mechanism, I think it's very interesting that I'm interested because, like, for example, I brought up the EGFR example. Lung cancer has been the long enough tumor type that had targeted therapy for TKIs, EGFR mutations. We see that I see them a lot, like a couple of different EGFR mutations show up. And then it's interesting that some of these, I had one case that had 3 EGFR mutations in when patient progressed, and having those mutations being in a cis or trans is also important to know. And then there were like case studies that showed like they might be even in trans, and then after a few months they can be in cis. So it's very interesting field to look into those as well. And it's not just looking at, like, for example, if it's a TKI, not just looking at EGFR mutation. Now we're looking at like MET amplifications, some other genomic events that I will call it, that would show up that it was not an original tumor, that these could be the resistant mechanism, that they are in the same pathway and they have like an activating the downstream pathway. We see that BRAF fusions we see in or another BRAF class 2 or class 3 mutations we see in patients treated with MEK inhibitors and BRAF inhibitor combination for class 1, which is BRAF V600E. So we see those mutations and fusions as well as a resistant mechanism. I think we need to have open mind in reporting those variants with and different genomic events in patients that they have been on treatment. I also want to emphasize that we need to also be careful about CHIP mutations. Also, not a lot of laboratories report those, but those might be secondary mutations during the treatment that they show up that might a discussion came up, like when patients get treated with PARP inhibition, they have heme malignancy risk, and nobody looked, or not a lot of people look at the CHIP mutation that they show up through the treatments. Maybe we should follow those as well to understand which one of these patients may be at high risk of showing heme malignancies due to the secondary CHIP mutations because of the treatment with PARP inhibition. So these are different interesting topics that we need to keep in mind from the laboratory side and the clinical side, and to prevent any of those resistance to therapy for these patients.
Great, thanks. Yeah, I appreciate that perspective about kind of therapy-related changes in the genome and what that would mean, including CHIP mutations, reversion mutations, things that can morph the tumor into something else or give you a comorbidity like a heme malignancy. Very cool. Hey, does anybody have any questions? I see Andrea has his hand up. Go ahead.
Oh, thank you. Sorry, my camera is not working today. Great presentation. I was wondering whether maybe I missed it also. Is there a kind of a time frame also where we can assign these reversion mutations in terms of the treatment journey, let's say? Is there a, they appear after 6 cycles or a longer period of time? Is there a time frame that it can be associated with those?
So the short answer is I don't know. It might be different patient to patient. But usually it's better to me every 6 months to do the testing if the insurance companies, just follow sequential blood testing for these patients to see if we can detect those mutations, but not, I think the payer issues right now, but I think what has been in practice, at least in my institution, is when patients stop responding, then we're going to do another testing, which I really think we should be doing before that happens, so we were ready and we know that's happening. But that's a really good point you brought up in terms of in general, big picture, not just specifically for BRCA reversion or any reversion mutation resistant mechanism. We should have the sequential testing for these patients and the blood samples, the less invasive ones, so we can detect those and understand, oh, this patient just had T790M for a TKI right now. And also, if we're doing a blood test in a sequential manner, we need to have a baseline as well to be able to have a comparison and see the evolution of the tumor throughout the treatment.
Thank you.
So I had another question. You mentioned the importance of understanding whether mutations were in cis or trans. How does your laboratory go about figuring that out, especially, with like short read sequencing that can be fairly tricky if the mutations aren't right next to each other?
Yeah, the clinical laboratories, they're not telling me that when we're sending the samples. They just say likely, because they just look at the variant frequency and they say they're likely to be cis or trans. But yeah, I think long read is what we need. But that's a great question. I wish we could have an answer. But I think to me, when I'm trying to present this case to clinicians, I communicate with laboratories all the time, and they they understand what I need, and they try their best what they can do with available information that they can provide to us. But I think at some point we really need to understand all this cis and trans in the clinical report. That's what I'm hoping I can see. That really helps with all the resistant mutations and mechanism and some other mechanisms that we're looking for.
Great.
Do you know any, do you have any better idea or suggestions to maybe overcome this in terms of the laboratory part?
Well, there are ways. I mean, you could probably do like a multiplex droplet digital PCR focusing on those, but that is expensive and probably would need to be customized for your mutation. So it's not super straightforward. It would be like it would be an extra. And if you're wanting that information on the clinical report, it would delay the turnaround time. So yeah, otherwise, I think it's reasonable for clinical laboratories if you have mutations that are in close proximity to assess the trans on the report. But I realized that a lot of time that's manual effort on the background. So if workflow or even interpretation workflow is automated, you don't necessarily have that step kind of built into the workflow. I know at Mayo we do if we can, but we don't always have the information we need to make that judgment.
Yeah, maybe that's something that clinical laboratories need to consider for future.
Yeah. Any other questions? I was wondering if folks who run databases and knowledge bases on the call have any insight on how certain mutations are annotated. So do we have specific annotation for potential reversion mutations within our database and knowledge base infrastructure?
That's a good question.
That's put you on the spot, but Cheryl, I see you're on the call.
Hi. Can you, I missed part of the question. Can you repeat the question?
Yeah, so do you have specific annotation for mutations that are known reversion mutations within the database infrastructure? Yeah.
So yeah, I mean it's super complicated, right?
Yeah.
Because if you get a mutation that could, so most of the reversion mutations we see are these in-frame deletions that just remove the culprit and are functional themselves. So by themselves, if they occur, if you get one of these in-frame deletions, it's not probably doing anything. So it's basically a VUS if you don't have another mutation that's within that area. So we handle it in our system using interactions. So it is a manual process to some extent, because if we actually look at the case, if we have multiple mutations in BRCA1 and BRCA2 or any of these other PALB2, RAD51, a couple of the RAD51 genes, and see, is this okay? There, it looks like there's an in-frame deletion. Does it include some of these others? We can't know for sure if it's in cis or trans, but it's highly suspicious that if you have a frame shift that would be removed by this in-frame deletion, that it's likely to be a reversion. And so we report them as likely or possible reversions, but you know, we can never be certain unless a client is doing long read. But that's how we handle it. It is largely manual, and if they occur by themselves, we do report them as VUS because they can't be reverting anything.
Yeah, that makes total sense.
I guess
Go
in
ahead.
Civic, the molecular profile functionality would help to support this by allowing you to explicitly say like this interpretation is for the combination of these two variants together, so you can have that context and it can be separate from how you would interpret them if you saw them by themselves.
Yeah, and that is how our system works in terms that we have in our system we call it interactions, but the reporting functionality will know, we can set up interactions so that the reporting functionality will notice that there are these two mutations that have been seen together and will pull in different content to reflect that. But it does require some manual review.
Can I ask a question, Cheryl, Malachi? So how do you distinguish like if between that and a complex variant? Like if it's
like if you have, you mean like if there are two frame shifts that could be an in-frame deletion if you're phased together?
yes.
Yeah, I mean, we have to, from our perspective, we don't know, like, because we don't have the information often, usually, of whether they're in cis or trans. We have some clients that will supply us with information saying this is a likely reversion based on our chemistry that we can tell that they're in cis. And in that case, we can customize the interpretation to say this is a likely reversion. Otherwise, it's a kind of a guessing game of we have a scientist that is looking at the case and saying, all right, these are really close to each other and it's two frame shifts on either side of a known, nonsense mutation or something. It's really likely that that's what's going on, but we can't be sure. And so that's how the language is crafted.
Yeah, that's what is what I was thinking. And every time I'm looking at this, it's just like, okay, I look at the patient's treatment history, but that cause issue, if we're looking into those de novo like pre-treatment cases, that we don't have any information about the patient's not being treated for any of these therapies, then what we need, what should we do with them? I think that's the big question, because these are the patients that they have some of those mutations de novo before these therapies. They may not respond, but we don't know,
right?
Because there's no way to say if we don't know the treatment.
Exactly. No, that's absolutely true. And I think in general, I have to go back and check, but I think we don't suppress the therapies in these cases because we don't want to take something off of a report and have a physician not see it, but we want to alert them to the fact that they might not respond, but we don't have enough of the information to make that call. So we just try to give as much information as we can, say, if there is a deleterious mutation here in BRCA that surpasses all of the reversion that you've got, the patient might respond to a PARP inhibitor, but we want you to know that we see this. So if there's something else you want to try, that might be wise. But, we can't make that decision. We can just present the information based on what we have.
Yeah, thank you. These are the challenges we're facing.
Of course, yeah.
Also in the clinical side as well, because when I'm presenting these to physicians, I sometimes I have no answer. Like,
yeah,
it's sad, but at the same time, it's exciting for a science part that we have a lot of work to do.
Yeah. Yeah. And I think with long read technology, as that becomes more and more, gets more adopted, especially in the somatic space, we'll be able to tell, like, oh, this is in cis or this is in trans and this is a reversion. But right now it's a lot of guessing.
I agree.
Yeah. But educated guessing.
That's great.
Thank you for your talk. I enjoyed it.
Oh, thank you. Thank you for the discussion.
Sure.
Well, kind of backing up for another kind of avenue of discussion here. I was wondering what kind of proportion you've seen of patients that do not get reversion mutations versus patients who acquire multiple reversion mutations, and if there's any like interesting aspects there, if it seems completely random.
In my setting is random. again, I don't see them a lot. So that's why it's just like, I don't have a lot of data to back that up. But it's completely random. I think when we do tumor sequencing only, is less likely we see multiple reversion mutations. When we do blood testing, in a blood testing, we see multiple reversion mutations. That it could be different reasons. Sometimes the tumor sequencing is not detecting, or if they're detecting, it's below the reporting range, they're not reporting it. But you know, the blood testing, circulating tumor DNA testing, they report all of them. So I myself had a couple of patients with multiple, and it was only detected by the liquid biopsy, and tumor sequencing only detected one, or reported one.
That's really consistent with what we see as well, like with the liquid biopsy, especially for what we believe are likely heavily treated patients. There are multiple, you'll see lists of of BRCA mutations, multiple, and trying to tease out what may or may not be a reversion of what can get really complex. And fortunately, it ends up that exactly what's a reversion of what kind of doesn't matter in the end, that just commenting that there are multiple mutations here that are likely reversions of each other, and we don't know what the ultimate result is, right? Because especially with ctDNA, if there's anything that's not reverted that ends up taking over, then it's going to be deleterious. So it's impossible to tease it out.
That's
But
really
it's
interesting.
Yeah.
Yeah. I guess I'd never considered that liquid biopsy would pick up more than the tumor assay with
Yeah.
that.
Yeah, you get all of the mets, so you can get multiple different mechanisms of resistance, um and then overcoming of that. It gets really tricky when you have a heavily treated patient.
So I'm wondering if it would be, I mean, are oncologists encouraged to do liquid biopsy for patients that are undergoing platinum therapy? Or is there any encouragement there so that you can pick up these resistance mechanisms?
I think it is I keep using the word tricky. It's tricky on many levels because it's expensive to keep treating, and not all insurance company or testing, and not all insurance companies will pay for it, and not all insurance companies will even pay for one liquid biopsy test when you've had a physical biopsy. So it depends on the patient's insurance, on the patient's ability to pay, and then it's also complicated to figure out where, like, when you do a liquid biopsy, you don't know where each of the mutations are coming from. So they could be from the primary, they could be from any one of many mets, and so you don't know what's actually driving the tumor that's growing. So there are pluses and minuses. You can pick up things that you wouldn't otherwise pick up from a single biopsy site, but you don't always know which of those things is relevant. You can sometimes make a guess based on the variant allele frequency, but it's complicated.
No, I agree with Cheryl. That's the same challenge that I have. And I can give you, if you have a second, I have to give you an example of a patient with esophageal cancer. Recently, we had a liquid biopsy, and the liquid biopsy identified EGFR T790M. And I got so excited when I saw the report. I said, well, this should be germline, because, and the variant frequency was higher than other ones that they detected, but not too high to consider this germline. But you can never say with the variant frequency there. And got so excited. I said, well, esophageal cancer, why we have EGFR T790M. So I suggested to do germline testing. Germline testing, we know that EGFR mutations, T790M is one of them that could be germline for lung cancer. And it was negative for germline for T790M. And I'm still in question where that T790M came from. With esophageal cancer, no treatment. Where that is from, I still don't know. And I couldn't answer our oncologists when they had that question.
Yeah, that's unusual. That's really interesting.
I even called the laboratory. I said, did we have a sample swap or just want to make sure that everything was actually accurate, but everything was accurate.
Yeah, I'd wonder too, because esophagus, could it have been an invasion from a lung tumor that's in the esophagus? That's, I don't know. That's
Yeah.
interesting.
So although these liquid biopsies are really helpful in many ways, but also challenging to know what to do with them when it comes to the clinical application.
Yeah.
For physicians.
Right. It's like you need to have like a really good handle on the pathology of the tumor, and understand, what tumors you're actually working with. Yeah, if we're going to use liquid biopsy in that way. Interesting. Cool. Thank you. It's really interesting. I guess the bottom line is it's complicated.
Yes. We are still in infancy. I'll always say that. Although we made decades of work in the science, but we're still in infancy when it comes to oncology, at least.
Sounds good. Are there any other questions or comments? Right. Hearing none, I think we'll finish up a little early here, give everybody 10 minutes back. But thank you so much. I really appreciate your viewpoint and discussion and all the education on reversion mutations that we got today. So thanks so much for sharing.
Oh, thank you. Thank you for the great discussion.
Thank you.
Thanks. Bye.
Bye-bye.